So in pediatric CT surgery, when we cannulate for ECMO, most of the cannulations are on infants and on neonates. And because of their size, we normally cannulate the right jugular vein and the right carotid artery. It's usually done through a small transverse incision, and the blood vessels are located just medial and posterior to the sternocleidomastoid muscle. And so I have with me here an arterial cannula with the red cap and a venous cannula with the blue cap. And so after giving heparin, I usually control both blood vessels on the cephalad portion, ligate both of them, and I usually insert the arterial cannula first. The arterial cannula, both of these cannulas have markers on them, and for an infant and a neonate, the arterial cannula I usually insert maybe to the second mark, sometimes to the third, and if it's an infant it's a little bit larger, but placing the arterial in too far can risk damage in the aortic valve and sometimes compromise flows. The venous cannula, what I normally do, so the venous cannula has multiple holes. I'm not sure if you can see that, but there's an end hole and there's multiple side holes on the venous cannula to assist with drainage. And so one rule of thumb I use is I palpate the costal margin of the baby, and that is normally on the outside of the body. I see where the tip of the cannula hits the costal margin, right about where the jugular vein is. And that gives me a rule of thumb as to how far to place the venous cannula. And so in neonates, it usually ends up being around the 7th or 8th mark on the cannula. And other children, we just have to judge it based on that rule of thumb. We always obtain a chest x-ray afterward. I always check with the perfusionist to be sure that the flows are adequate, that the pressure on each cannula is appropriate. Let's see. So in some children we do VV ECMO. So we use the crescent cannula. This is an Avalon cannula, which is very similar. But the idea is that this goes in the jugular vein, and one of the ports brings blood to the ECMO circuit, and the other takes it back to the patient. And so the advantage of this is that the artery does not have to be used. Patients can often be extubated if they're a little bit older. Because it's a venous cannula only, it's a little more stable situation, so it allows for more movement and motion and physical therapy and things like that. And so the one issue that I've encountered with the smaller veno-venous ECMO cannulas is that their position is somewhat finicky, and so it just doesn't seem like there's much, there's not a wide therapeutic area in which they can function. So it seems like they have to be in one exact place, and sometimes the flows can change because the patient's small, the ports are located very close to one another, and so that can sometimes make it challenging. So at our institution, for neonates or small children, we generally do VA ECMO, even if it's purely respiratory, just because we have had some issues with VV ECMO and flows. Many of the respiratory patients are on cardiac support anyway. Many of them are on epinephrine or norepinephrine, and so our team feels nervous about just using VV, although we do know that once the blood gases get better, the cardiac function and blood pressure usually improves. So.